Morning.
Morning.
We do a presentation this morning on airway management, and we'll be talking about the anatomy of the respiratory system. We'll discuss the physiology of breathing, including ventilation, exhalation, oxygenation, and respiration. We're going to recognize adequate versus inadequate breathing, and we'll talk about pulse oximetry and how that comes into play. Be able to explain and assess a patent airway on your patient, describe the importance and techniques of suctioning, be able to measure and insert airway adjuncts, including an NPA, an OPA, and an I-gel. We will do that in our skill sections afterwards. You'll be able to describe the importance of providing supplemental oxygen, describe the indications for oxygen delivery equipment, including your BVM, your nasal cannula, and non-rebreather, and describe the science associated with adequate versus inadequate artificial ventilation. And then last, we're going to talk about foreign body airway obstruction based on the new guidelines for the American Heart Association. So here we have the upper airway, and we know that the airway, upper airway consists of the pharynx, which is in the back section here. We have the nasopharynx. What is the purpose of the nasopharynx?
They help filter with the hairs. It'll filter the air
Yep.
as it goes down.
Exactly, as well as warming it. Okay. And then we have the oropharynx, which is in the back, posterior portion of the oral cavity. And then we have the epiglottis, which is right here. Then the larynx. The larynx is where the upper airway ends and the lower airway starts. And then we have the glottis, which is the space between the vocal cords. It's the vocal cords that, you know, when we choke on water, when we suck in a little bit of water, we have that spasmodic closure. Okay. So right in this area here is where we're having the larynx and the division between the upper and the lower airway. So with the lower airway, again, you have the larynx, which is right here, which is the division. You have the trachea, which is your conduit for entry of air into, sorry, didn't need to do that. Entry of air into the lungs itself. And it divides at the carina, right through here, into the right and to the left main stem bronchus. We have a pleura that surrounds the lungs. We have a visceral pleura, which is a thin, slippery membrane, and then a parietal pleura that lines the inside of the thoracic cavity. The whole purpose of that is a small amount of fluid that helps breathing. So it reduces the friction when we are breathing. So from the bronchi, we go into the bronchioles, over on this side here, which then leads into the alveoli. And we know the alveoli is where the oxygen and the carbon dioxide diffuses. And this is what we need for life. This is essential for life. So the oxygen diffuses through the lining of the alveoli in the pulmonary capillaries, which are right in through here, and is carried back to the heart and the body. And the carbon dioxide, the CO2, which is a waste product, diffuses from the pulmonary capillaries into the alveoli, and that's exhaled and removed from the body at that point. We'll talk a bit about the physiology of breathing, external and internal. Included in that will be ventilation, exhalation, oxygenation, and respiration. So for the physiology of breathing, we know that the respiratory system and the cardiovascular system have to work together to ensure a constant supply of oxygen. It brings nutrients to the cells in the body. We know that the CO2 is the waste product, and it's removed from every cell as well as exhaled. So for ventilation, it's essential for life. When we are providing support, respiratory support for a patient, we are ventilating that patient with oxygen. It's one of our highest priorities. What's the other highest priority? If a patient's bleeding out.
Stop the bleeding.
Yeah, stop the bleeding, exactly. So we have XABCs. So one person can work with the bleeding out, and the other person can work with the airway. Okay. So when a patient inhales, it is active, and it does require muscle. So as we inhale, our diaphragm and intercostal muscles will contract, and that allows the air to enter into our lungs, and our thoracic cavity enlarges, and the diaphragm moves down. So with exhalation, it's a passive process. Doesn't normally require any muscular effort. There is no muscle tissue in the lungs. So it does rely on movement of the chest supporting structures. So if you think about the whole thoracic cage and the diaphragm, the intercostal muscles, all the accessory muscles that we use to breathe, what kind of injuries would we have or could a patient have that would interfere with the movement of the chest and obviously interfere with the respiratory status?
When a crushing wound or something like that in a vehicle wreck or in a confined space,
Mhm.
if it would push down on their chest, they wouldn't be able to do either one.
Mhm.
So,
Exactly. How about burns, second and third degree burns, anywhere, from the airway itself all the way down? If you have second and third degree circumferential burns all around the chest, they're not going to be able to expand their chest. How about a spinal cord injury? Yeah. Okay. Even a foreign body airway obstruction. Okay. So let's talk a bit about oxygenation. This is the process of loading oxygen molecules onto the hemoglobin in the bloodstream. And for oxygenation to occur, the percentage of oxygen inhaled during ventilation must be adequate. So then we're going to determine how much oxygen a patient's going to need when we assess our patients. So we do know that ventilation without oxygenation can occur where oxygen levels have been depleted. So if we think about what areas, where could a patient be? Where do you find a patient where oxygen would be depleted?
Drownings?
Where?
Could that be drownings?
It could be drowning. How about an enclosed space? I don't think we have any mines around here, but a mine could be one. How about, I know up north we had 2 telephone workers who were in the manholes and they both suffocated. Carbon dioxide as well. Okay, how about high altitude? I remember in Maui we would go up to Haleakala and it's 10,000 feet above sea level, so the higher you get up there, the harder it is to breathe. The air is that much thinner. Let's talk a bit about respiration, which is a process of exchanging oxygen and carbon dioxide. The external respiration is the process of exchanging oxygen and CO2 between the alveoli and the blood in the pulmonary capillaries. So if you look here we have our alveoli. We have the surfactant around here as well, and the surfactant does help keeping the shape of the alveoli, as well as it helps it expand and contract, and it helps as well as bring in the oxygen and the CO2 in and out of the alveoli. So looking at this, coming from the pulmonary artery, we have deoxygenated blood. It's going past, in the capillaries, past the alveoli. It's picking up oxygen, and it's going to drop off CO2. So as it drops off the CO2, that's going to return to be reoxygenated, and then this oxygenated blood continues on to the pulmonary vein in the heart, and then it's dispersed throughout the rest of the body. Now, internal respiration is actually cellular respiration. It's the presence of oxygen in the cells. The oxygen in the cells converts glucose to energy. And without the oxygen, the cells don't completely convert glucose to energy. It could produce a lactic acid or other toxins, and when they accumulate in the cells, we can't get rid of them. So this is called anaerobic metabolism. If these are not corrected, the patient will eventually die. We could find a patient, in late stages when they're not exchanging proper oxygen and carbon dioxide, and they produce toxins, and we will have to deal with them in the field. So this is really why the adequate perfusion between circulation of blood within an organ and external ventilation must be present. Failure to meet the body's needs of oxygen might result in hypoxia. Patients with severe respiratory and circulatory compromise should receive increased concentrations of oxygen regardless of their underlying medical condition. That could even be for patients who have COPD. They usually know how much oxygen, what level they're at, but for the short period of time we as EMTs are with that patient, it's not going to hurt that patient if we give them high flow oxygen for that short period of time until we transfer care over to the medics. So the process of ventilation, oxygenation, and respiration, the overall goal is to deliver an adequate supply of oxygen to the cells. So by recognizing the signs and symptoms of inadequate tissue perfusion and oxygenation, we can immediately intervene for our patient. Look at your patient. I can't stress that enough, to look at your patient always. Listen to them as well, they know. So pathophysiology. You know that multiple conditions can inhibit the body's ability to effectively provide oxygen to cells. It is important to recognize these conditions quickly and correct them immediately. So we talked a little bit about factors affecting the central nervous system. There is a complex series of chemical reactions that are constantly taking place, and these are chemoreceptors. And the chemoreceptors will monitor the levels of oxygen, carbon dioxide, hydrogen ions, and the pH of our CSF, our cerebral spinal fluid. And then it provides feedback to the respiratory centers to modify the rate and the depth of the breathing based on the body's needs at that time. We have central chemoreceptors, and those are in the brain, in the medulla oblongata and in the pons. And these respond quickly to slight elevations in carbon dioxide or a decrease in the pH in the CSF. The peripheral chemoreceptors are in the carotid arteries in the heart, the carotid arteries as well as the aortic arch in the heart. And these are sensitive to oxygen levels in the arterial blood as well as decreased pH levels. So when the serum carbon dioxide, the carbon dioxide in the blood, and hydrogen ion levels increase because of a medical or a traumatic emergency, which involves the respiratory system, these chemoreceptors will stimulate the medulla to increase the respiratory rate, moving the CO2 and the acid from the body. So in this case, they would be blowing off CO2. Additionally, stimulation from the pons in the brain affects the rate and the depth of the respirations. So obviously, if either one of these is disrupted, the respiratory process will be affected. So let's talk a little bit about opioid overdose. What do we see in the field with an overdose of an opioid? What are the signs and symptoms of a patient?
Stop breathing.
In most cases they are, yeah. Yeah, they will have pinpoint pupils, right? If they haven't already failed in their respiratory, they're on the way leading to respiratory failure. They're gonna have a decreased heart rate, decreased altered mental status. What is our first line of treatment per protocol as an EMT? So the first line of treatment would be airway.
Okay.
Yeah. Mm-hmm. I've learned, at the teaching the paramedics right now, that per protocol here in Brunswick County, it's preferable that we maintain the airway, and if we can oxygenate this patient appropriately, keeping the SATs at 94% at least, by bagging the patient and putting in an oral airway, or any other airway that would be effective, then we can continue doing that. If we give Narcan, we can give Narcan nasally. So if we have to give Narcan, what are we stopping? The ventilations for our patient, yeah. But you're correct, Narcan is the antidote for this. But for our level, let's let the medics take care of that. Mm-hmm. How about carbon monoxide poisoning? What do you see in a patient with carbon monoxide poisoning?
Blue lips, confused, headache, nausea,
Mm-hmm.
if they're awake,
Yeah, so what's their respiratory status?
bad.
Mm-hmm.
It's bad. They might be breathing, but they're not breathing enough oxygen to make it work. So
Right, exactly. So what are we gonna do for these patients?
we need to remove them.
Remove them first?
as quickly and safely as we can, and then start with airway and
Mm-hmm.
go from there.
Mhm.
Monitor vitals.
High flow oxygen,
Mhm.
yeah, definitely. If they're alert, we could use a non-rebreather. So let's let's just talk a little bit about hypoxia and the time it takes for brain damage to occur. You know, there's some cardiac irritability from 0 to 1 minute. I say 0 to 2, but anywhere from 4 to 6 minutes, you're going to start seeing a patient declining very quickly. A patient without oxygen, in 6 to 10 minutes is very likely going to die, and then greater than 10 minutes, you'll definitely see irreversible brain damage. Talk about the signs and symptoms of hypoxia. Early signs, if you look at this, they're all pretty similar, other than the tachycardia. You know, your patient is really anxious right now. They can't breathe, and they're freaking out. So they're restless, they're irritable, they have increased anxiety, they're very apprehensive, their heart rate has increased. Late signs could be changes in mental status. They could have a weak, thready pulse, cyanotic, short of breath. If a patient is unable to speak in short sentences, then you know that they're having a difficulty breathing. If a patient's telling you that I can't breathe, believe them. They know better than we do. So again, you're looking at your patient. So recognizing adequate versus inadequate breathing and the factors affecting ventilation, which would be intrinsic and extrinsic. So if we look at intrinsic, I think of these more as medical issues with the patient. This is internal. So you have an infection. What kind of infection would be so severe that a patient would have difficulty breathing?
Bronchitis,
Bronchitis.
something that affects the bronchioles,
Mm-hmm.
COPD.
Yeah.
Pneumonias.
Mm-hmm. Yep. Even a patient who's gone into septic shock, who hasn't received treatment for a long period of time, we can see them in the field as an EMT. We can see them in late stages of septic shock. So again, we're thinking 100% oxygen, high flow. How about allergic reactions, angioedema, and bronchoconstriction? What kind of allergic reaction could we see out there that we can treat medically?
Mild, moderate, and severe. All three types we can treat as a basic.
Mm-hmm. Okay. What would be an example of angioedema? A patient who has angioedema, swelling of the mouth, the lips, the throat, bronchoconstriction.
Bee sting.
Yeah, bee sting.
Bee sting.
Anaphylaxis.
Anaphylaxis.
Yeah, anaphylaxis.
Exactly, right. So with anaphylaxis, what do we see in our patient? Now with an anaphylaxis, this is more like what's called a vasodilatory shock, so the patient's blood vessels are expanding and their blood pressure is going to tank. It's going down really fast. What else would you see in this patient?
More than 2 bodily systems affected.
Yeah.
Hypotensive, possibly.
Mm-hmm. Exactly. How about GI problems? Nausea, vomiting, things like that? Okay. With this, wait, no. You want me to continue, Kat?
Go ahead.
Okay. So with this, we can give what? What would be the first thing we want to try to do for this
For
patient?
moderate, we're going to go with epi. With a diphenhydramine for a moderate, just one bodily system, maybe sneezing.
Mhm.
And then for more severe, we can definitely do diphenhydramine, but we can use albuterol as well.
Mhm.
And then for the severe, we're going to use the epi.
Right. So tell me how you get an epi.
We're going to give it IM 0.3 to 0.5 for an adult, or 0.15 for pediatric.
Perfect. Okay, so you're giving it IM in the upper outer aspect of the thigh. Yeah. How long is it going to take for this to peak? Which would be about the same time that we can repeat a second dose on this patient.
5 minutes?
Yeah, exactly 5 minutes. And that's going to be a long 5 minutes because if you're trying to maintain their airway, and they're very anxious at this point. Exactly. Okay.
And also depends on if they've ever had an allergic reaction before and had this treatment done to them. So it could take another dose or.
Mm-hmm. in a lot of cases, it does take a second and maybe even a third dose. So if your patient is receiving epi, we won't give diphenhydramine because they're altered mental status. Also, we could do albuterol in the field if the epi is not working in between the doses of epi. Okay. Talk to your patient, try to calm them down as best as you can. Good eye contact, that's what I say. Okay, and touching them. Touch them on the shoulder, touch them where they know that you're there with them and you're supporting them. How about unresponsiveness, tongue obstruction? Right? What are we going to do with the tongue obstruction? You can reposition the patient's head, right? Head tilt, chin lift. Think about that. We talked about opioids, medication which depresses the CNS, trauma to the head, and spinal cord. We have somebody who dives into the water and affects the C1, C2. I mean, at that point, they're not going to survive, but you know. So we have to definitely maintain C-spine as well as maintain the airway. And how are we going to open the airway in a head injury or spinal cord?
Jaw thrust.
Exactly. How about a patient with MS, muscular dystrophy? Yeah, they're not able to move any of these. As this disease progresses, it gets worse and worse. Asthma and COPD, bronchoconstriction. So let's talk a bit about the external, the extrinsic trauma to the airway. Remember a couple months ago I showed you the video from Nurse Gwenny where that little kid was on his bike and he had his handlebars, he fell, crushed his trachea. They didn't realize what was going on until he got into the emergency department, but his trachea had been collapsed. There's really nothing that we can do in the field other than try to supply supplemental oxygen and try to calm them down. Trauma to the chest resulting in structural damage to the thorax. We talked a little bit about that. Numerous rib fractures or flail chest. You'll see a patient, they're going to always do this. If they have flail chest or rib fractures, they're going to support like this. So that'll be a key sign for you. This is how they're going to be splinting it. We talked about second and third degree circumferential burns, hot gases as well, breathing in hot gases. So let's talk a bit about hypoventilation, which we know is slow and shallow breathing. So if our production of carbon dioxide exceeds the body's ability to eliminate this gas by ventilation, then the partial pressure of CO2, which we call PaCO2, rises, no longer keeping up with the normal metabolism. And this results in a buildup of CO2 in the blood, and this is called hypercapnia. Hyperventilation, rapid or deep breathing. This occurs when carbon dioxide elimination exceeds the CO2 production. So for example, if a person with anxiety tends to breathe very deeply and rapidly, the CO2 is eliminated at a faster rate than the body produces it, causing the CO2 in the blood to fall below normal. This causes dizziness, numbness. They could have numb lips, it's hard to say. Just think about that with these patients. We don't use the paper bag anymore. Back then, what's the best thing that we can do for this patient?
You want to calm them down.
Yeah, exactly.
In
Calm
through
them
the nose,
down.
out through the mouth. Smell the roses, blow out the candles.
Exactly. So, thank you. Circulatory compromise. When the circulatory system is not functioning efficiently, respiration cannot occur, right? Because they both go hand in hand. So when the circulatory system is compromised, perfusion becomes inadequate and the oxygen demands are not met. Obstruction of blood flow is typically related in trauma injuries. These conditions inhibit the gas exchange at the tissue level because of the adverse effects on the respiratory and the circulatory systems. So let's talk a little bit about a simple or a tension pneumo. What is a tension pneumo? And what could cause it? It's where there's a collection of air in the pleural space. A patient could have a crushing injury. They could hit the steering wheel without airbag deployment. You're going to have volume and pressure. And what it's going to do is it's going to collapse the involved lung where the injury is, causing a shift, a mediastinal shift. So this is our mediastinum, right? So when you see a mediastinal shift to the other side, what are you going to see in your patient? Yeah,
Yeah.
exactly. Tracheal deviation, chest pain, increased chest pain, increased respiratory rate, increased heart rate. Now their blood pressure is also tanking as well. Could you see JVD in this patient? Because it's pushing?
I'll say, yeah.
You could. In most cases, JVD would be a late sign, and they wouldn't see that until the emergency department, but very well, you could see it out in the field. How about an open pneumothorax, a sucking chest wound? What do we do for these patients?
Cover it, seal 3 sides.
Yeah, exactly. How about a hemopneumo, which would be blood and air in the pleural space? This one we're not going to be able to do anything about. I mean, you're going to see the same symptoms as you would a tension pneumothorax. We don't want this kind of patient, but we'll see them out there. So high flow oxygen. If you have to assist in ventilations, then assist with high flow oxygen. How about a patient with a PE? How do they present? Pulmonary embolism. These patients could have severe chest pain and immediate shortness of breath. A PE would result most likely from a deep vein thrombosis. You know, the patients who are traveling for a long period of time will start in the calf and work its way up. Can patients die from PE? Yeah, and quickly they can as well. How about patients with CHF and cardiac tamponade? Now these patients have fluid accumulation around the heart itself. I'm not remember in EMT class if we learned Beck's triad, but the patient will be hypertensive. You could see JVD on either side. They will have muffled heart sounds. What does that mean, muffled heart sounds? Reduced sounds, and if there's fluid in there, it's not going to be as clear as it would if you're auscultating bilateral clear breath sounds. Okay. They could have tachycardia. They'll be diaphoretic. They could be cyanotic. Okay. So a patient with cardiac tamponade, there's nothing that we can do for these patients in the field other than support them emotionally and with ventilatory. These patients need a pericardiocentesis in the emergency department where they're sticking the needle in and they're aspirating all that blood out. So, and they too are going to have increased chest pain and increased work of breathing. So again, support our patients as much as we can emotionally. When the body is in a state of shock, oxygen is not delivered to the cells efficiently. So let's talk about hemorrhagic shock. When would you see hemorrhagic shock? So hemorrhage is bleeding out, right? So where would you see hemorrhagic shock?
She had a gunshot,
Yeah?
or just a big bleed, major
Laceration.
laceration.
Would you say, Kat?
A laceration.
Laceration?
Yeah.
So what is our first line of defense for something that's bleeding out so much?
Tourniquet.
Yeah, pressure, direct pressure, and then tourniquet. What if the patient has an open femur fracture? How much blood could they lose? About 2 liters. It's a lot of blood. So on average, how much does, say you guys size-wise, how much does our body hold?
6?
How many liters?
6?
Yeah, 5 to 6 liters. A pregnant woman would carry more because she's, taking care of 2 bodies. So we have to think about that. How about vasodilatory shock? That would be, again, anaphylaxis. It could be sepsis. So what's happening with the diameter of the blood vessels is increasing. So the blood pressure goes down, again, because it doesn't have a lot to push against. These patients are going to have severe anxiety. Okay. I can't stress enough patient assessment, looking at your patient. Look at your patient, do they have a patent airway? That's the first thing we're going to be looking at. If you can see obvious bleeding, then we stop and we deal with the bleeding first, and then the airway, XABC. Is your patient responsive or are they unresponsive? Look at that. When you come into a room and you see a patient sitting in a chair doing this, what's your first thought?
Cardiac.
Could
Or
be.
Air issues, yeah.
Yeah, right. That's called tripoding, right?
Mm.
So you know that patient is in difficulty. Right. How about snoring respirations. What would we do with the patient with snoring respirations?
Try to readjust and go from there, give them some air, most likely, depending on what their vitals are, but
Mhm.
readjust their airway.
Yeah, absolutely. And possibly put in a oral airway to help keep the tongue from obscuring. Vomitus,
Suction.
suction, gurgling sounds. What would cause gurgling sounds?
Fluid.
CHF.
Yeah, CHF kind of, but a patient with CHF would have more like pink frothy sputum. Gurgling could be bleeding into the air. Okay. And if we create problems by hitting the gag reflex, that's our problem. We don't want to do that. So recognizing adequate breathing, we know that the normal rate is 12 to 20 breaths per minute. We look at the patient's chest rise and fall. Are they getting adequate tidal volume? Is the pattern of breathing regular? Are you hearing equal and bilateral breath sounds when you're auscultating their lungs? For patients with inadequate breathing, as I mentioned before, any patient who complains of a respiratory problem, difficulty breathing, believe them and help them immediately. Anything that's less than 12 breaths per minute or 20 breaths per minute, we want to assist these patients. Normally in the emergency department, we would leave the patient that was breathing on their own at 12 breaths per minute, provided they were maintaining an adequate oxygenation. But we can actually assist a patient, and I'll go over that, with their breathing when it gets low or too high. If a patient is breathing shallow, that's inadequate. If they are altered in their mental status, because they're not going to be able to maintain their airway. Any adventitious, which is abnormal breath sounds. What would be adventitious breath sounds that we could hear in a patient?
Wheezing.
Yeah. How about in a CHF patient? What would we hear when you hear fluid in the lung? It crackles? Yeah. Okay. We'll do that in class one day. We'll just go over all breath sounds, and it'll be fun to do it that way. So a patient, if they're cyanotic, how are we going to tell cyanosis in a dark-skinned person?
Could be in the mouth area.
Yeah. Yeah, in their mucous membranes, you would see it mostly. Exactly. We talked about preferential positioning, a tripoding position. How about the sniffing position? When they're putting their head up like this, what they're trying to do is open up the airway as much as possible to get the air through, so they could be like this. Nasal flaring. Where do we see nasal flaring mostly? You can see it mostly in little kids and infants. Pursed lip breathing. Pursed lip breathing would be somebody who may have COPD. They want to try to blow off that excess CO2,